Good evening, everybody. Before I start, let me apologize for my laryngitis. Try to get through this as best I can and answer as many questions as I can for you. Tonight's webinar is on preparing for successful in vitro fertilization. And before we get started, I just want to say that this will be about a 20 to 30 minute presentation, followed by questions and answers. I ask you to submit your questions in the chat box next to the video window at any time you like. But it's perhaps a good idea to let it go on for a while so you can get an idea of the drift, and the questions will come to you more easily. Any additional questions, I invite you to go onto our discussion boards at haveababy.com. I frequent the SRM Las Vegas discussion board and the SRM St. Louis discussion board. So please go there with any questions, and I'll be there quickly to answer your questions. Within a few hours, you'll have your questions answered. Perhaps even a better venue would be to go to my blog called IVFauthority.com. Post any comments that you have there or questions, and I'll address them directly from the blog. All right. Now, without any further ado, one last thing, yes. If any of you would like to talk to me, call this number there, 800-780-7437. Perhaps write it down. You can call that number and set up a Skype consultation with me to discuss any issues as they pertain to your case. We'll spend an hour on the Skype dealing with every issue that you have, and I think you'll find that we'll cover a lot of ground and maybe give you a new insight into some of your problems. There certainly is nothing to lose. And you can either do that or visit our website, haveababy.com, as well. So then this presentation, as I said, is called Preparing for Successful In Vitro Fertilization. And as I always do, I'd like to start off with a basic concept. Everything I talk about in preparing for successful IVF is going to be geared towards understanding this very basic, simple premise. And that is that being successful with IVF is the same as planting a seed in soil in your backyard. Only here the soil is the uterine lining, and the seed is the embryo. This is a beautiful blastocyst, a 5-day embryo with over 100 cells, and this is the endometrium. Notice the inner trilaminar appearance. It's where the baby grows. Now, you cannot hope to achieve a successful growth of a plant without planting a good seed in a good soil. You can't plant a good seed in a bad soil or a bad seed in a good soil. And so it is when it comes to preparing people for IVF, the factors we need to focus on are those that are going to affect the quality of the seed, in this case the embryo, which is responsible for 75% of the success or failure of IVF, and then making sure that the uterine lining, that the uterus itself is receptive. And that the implantation process, the soil, is responsible for about 25% of success and failures of IVF. But for it to be successful, both have to work in unison. But before we go there and discuss the variables that are involved in each of these components, let's first look at what is involved in IVF being successful from the very get-go. When patients walk into my office, the most important thing on my mind the moment I see a patient is to establish a good relationship, an optimal relationship, and that requires affability and availability on my part to my patients. So at the initial consultation, where I would much prefer both partners be present, because when I see a couple or I see a case of infertility where only the female or the male partner arrives, it immediately makes me realize that there are deep-seated problems that have to be dealt with, because both have to be committed to what we're going to be doing. You can't just treat a woman in isolation or the man in isolation. The first thing then is to establish that feeling of comfort. Somebody once said to me, success is as important to establish an environment of caring as it is to give care. And I can't agree with that more. It's important that people sense your feeling of empathy for this to be a workable relationship. We call that the rapport between the doctor and the patient, and it needs to be ideal. It's pretty sad that the days have gone when a doctor would sit on the bedside of an ailing patient, hold their hand and comfort them. It's extremely important in IVF for patients, couples, to feel that sense of commitment and that sense of caring. Then comes the history taking, and that's very important because that's where you get the clues to put the puzzle together. Couples often come to me with a whole stack of records. I prefer to take the history first, discuss it from my perspective without looking at those records, and then once I form my own overall opinion, then to go to the records and supplement that opinion or alter it based upon the information I find in the records they bring. But the bottom line of all this is that information is empowerment. There's nothing more important than people leaving the doctor's office with a full understanding of where the doctor's coming from, what the basis for treatment is going to be. And then what I always do when people leave my office is I send them an email with the summary of the entire consultation on it, and with it goes another separate email with a list of topics that you find on my blog, IVFauthority.com, and I refer couples or patients to the blog with a list of those topics that they then can type into the search bar at the upper right-hand corner of the homepage of IVFauthority.com and click on it, because there are over 300 articles there. And by simply typing in the topic that I give you, which is going to be focused on your particular problem, you click on it, and that's going to take you directly to the article. And then, of course, there's the emotional preparation. Everybody needs to understand that IVF is an emotional roller coaster. No matter how good we are at it, no matter how good we are at providing a caring environment with affability and the best possible standards of medical care, it's always going to be a time of emotional concern. When people come into my office, I can immediately sense their consternation. Firstly, they don't know me, and so that's the first thing, and that's why I said earlier on, establishing that good relationship from the get-go is important. But it's also important to feed in and understand where the emotional vulnerability lies, and to help people understand that we're not just there for them to achieve a medical success, but also to help them get through it with as little emotional trauma as possible. I give all of my patients my personal cell phone number, because I believe it's so important for them to know that if they have a problem or concern that comes up when they leave me, that they can call me on my cell, and that they can, if I'm busy, just leave a number and I'll call them back. That helps me sleep better and helps them sleep better. Besides, it gives me the ability to be able to say, I told you to call me if you have a problem, so that if you don't call, you have to take responsibility if problems do not get resolved. The second part of the relationship is the clinical coordinator consultation. At my center in Las Vegas, I spend an hour with my patients, and as I say, it's followed by a letter, followed by a list of articles to go and read up on my blog, followed by follow-up information that I give them, but then I schedule them for a clinical coordinator consultation. And on the email I send them with all the list of articles to read, I also send a video link which contains a video tutorial by Linda. Linda Vignapiano is my clinical manager, who's been with me for almost 15 years. And Linda's phenomenal. So they get a tutorial, all patients get a tutorial that they can watch on the internet. It lasts about 40 minutes. They write down questions, and they can watch it as many times as they like. And then that forms the basis of what will follow, which is a clinical coordinator consultation for an hour long, where if you've already watched the tutorial, the patient has got a much better understanding of the process that they will go through with us, and Linda will fill in the blanks. And then there's a financial consultation held with Sharon Jockman, and Sharon is the administrator of the clinic. She discusses the logistical and financial issues, and we have, of course, got many packages. We also have a first responder plan where we significantly discount our services to people that are in the first line of defense for us as a community, namely the military, police force, firemen, nurses and teachers. In those 5 categories, we have chosen to discount our services very dramatically. There are also special micro IVF packages where we have to do much less work because these are younger patients who don't have serious immunologic or other problems that take a lot of time and effort. And these patients will also get a significant reduction in the fee structure. We also have what we call 2-cycle plans, where couples buy 2 attempts at in vitro fertilization at a rate that's about 20% above a single fee. But that gives them the option, if they don't have a baby, and it's not a pregnancy, but if they don't have a baby after the first fresh attempt, all the frozen cycles are free except for medications. And if that doesn't work, they go through the whole process again at no extra cost except medications and anesthesia. They get a second fresh IVF cycle and all the frozens that go with it. This really has no restrictions. Anyone can get into this plan. And then we have embryo banking plans where people who are running out of the biological clock, they have diminished ovarian reserve, or they're getting older, want to bank and stockpile their embryos, test them by CGH, and then come back for transfers once we've tested them all and we know over several cycles how many good embryos we've got. This is all the stuff that Sharon will discuss with the prospective patients. It's very important that this be done again in a very cordial and non-threatening relationship, and we tell our patients that with us there's never any exchange of funds, there's never any commitment until they go into cycle, so they can cancel, defer and walk away anytime they like without any penalty. And then comes the physical examination, and the physical examination is one where we do an overall examination of the patient, or if they're from out of state or out of country, and I'd say that 80% of my patients fly in from out of state and out of country to see me, we have their doctor do a physical exam and give them a release, evaluating all the things we ask for, including an ultrasound of the uterus and also a saline sonogram if one's not been done, to confirm that the uterine cavity, the fluid ultrasound, or the sonohysterogram as it's also known, allows us to check the uterus and make sure it's in good shape. And older women that are over the age of 40 will go through a more rigorous evaluation either with us or outside of our office by their own primary doctor, including EKG, including liver function testing, electrolytes, BUN, creatinine, lipid profile testing, and a variety of other things we do as part of a basic physical exam. And then, of course, the next thing is, once the patient's gone through all that, we have to be accessible and available for any follow-up consultations, of which there are several, both scheduled and unscheduled, with the clinical coordinator, Linda, and with me. So that is the establishment of the relationship. It's very, very important, cannot be overstated. So when it comes to the evaluation, the pre-cycle evaluation, there's several major categories we look at. You have to understand, I'm not going to be able to go over every minor little thing. Some of you will be able to ask me questions in the at the end relating to specifics, and I'll try to focus on it. But these are the categories that I'm now going to focus on. Evaluating the male factor, checking the ovarian reserve, a general hormonal endocrine assessment of the patient, testing for anatomical factors, mainly in the reproductive tract, making sure the immune system is intact and there are no impediments to the embryo attaching, and then genetic factors, which we're not going to go into in much detail here. Those are the tests for specific categories of patients. Ashkenazi Jews will be tested for Tay-Sachs, Niemann-Pick, people of Mediterranean origin for thalassemia, African Americans and Africans for sickle cell, and we can go on and on and on. There are many, many groups. And then there are specific cases where there's a history of a genetic predisposition, which we then go looking for more specifically. So let's start with the male factor. And here I'm not going to spend a lot of time. The basic semen analysis today is usually done by computerized assay. And we're looking for a sperm count where the count is above 20 million per milliliter of sperm, where there is at least a 40% or better motility rate, the sperm are moving, and we then break it down into the purposeful directional movement of the sperm, and then we look at the shape and configuration of the sperm based upon very rigid criteria we call the Kruger classification. We look for sperm that ideally have, for IVF purposes, more than 4% of the sperm being of normal forms. Now, this is very, very important to know, because in our program we do almost 100% ICSI, intracytoplasmic sperm injection, for which in SRM Las Vegas there's no additional charge. So we do ICSI, intracytoplasmic sperm injection, to fertilize the eggs because it gives better results. And doing this process doesn't harm the sperm harm the eggs in any way, provided that it's being done for the right reason. It's an excellent way to go. If you do ICSI for male factor infertility, where you really have no other choice, then you're dealing with problems that are related to male infertility that can increase the risk of certain types of deletional problems in the sperm chromosomes, that can lead to things like a higher incidence of male infertility in the offspring, or increased risk of miscarriage. These are not because of the ICSI procedure, but rather because of the indication for which it's done. And ICSI done when there's no male factor infertility at all does not in any way compromise the quality of life after birth or the pregnancy itself. The SCSA, or the sperm chromatin structure assay, looks for DNA fragmentation. It tells us whether the sperm is abnormal, and if the SCSA has a DNA fragmentation index of greater than 30%, we're concerned. Between 15 and 30%, it's okay, and under 15%, it's excellent. So we look for the percentage of sperm that have fragmentation of the DNA. What's important to know is that no matter how high the sperm chromatin structure assay shows DNA fragmentation to be, that does not preclude a successful IVF pregnancy. It just means that when it comes to doing IVF, you've got to be much more selective in choosing the sperm for fertilization purposes. The SCSA and other tests that measure DNA fragmentation, such as the tunnel test, TUNEL test, these tests are far more predictive of outcome with natural conception than they are following IVF, or with following intrauterine insemination than they are with IVF, because, as I say, even males that have very high DNA fragmentation indices can still propagate fully viable pregnancies through IVF. Then comes the endocrinologic male factor. Certain men have got low sperm counts simply because the pituitary gland of the man does not stimulate the testicles to produce enough sperm. There's an area in the testicle that is most responsible for sperm production. It is known as the Sertoli cell area. And then there's another area in the testicles that is responsible for testosterone and other male hormone production, known as the Leydig area. By measuring LH and FSH, LH stimulates the Leydig area, and FSH predominantly the Sertoli cell area, we can tell whether there's enough stimulation of sperm production. And if a man's got a low sperm count and we find him to have low FSH, we can then administer medications that will increase FSH production, such as Femara and or letrozole and clomiphene, or we can give men injections of FSH and in some cases HCG to improve sperm production. But when the FSH level is high and yet the sperm is poor, that points towards the testicles being the problem, with end organ failure, and if the testicles are not functioning properly, no treatment is going to improve sperm production. In those cases, we're going to do the best we can with the sperm the man produces. Again, treating reduced sperm production is only helpful really in cases where there is low FSH levels, or certainly low normal FSH levels. If the FSH level's over 7 milliinternational units per milliliter, it's highly unlikely that treatment with any medication is going to improve sperm production. There are other medications that are used besides endocrine, which also help sperm quality, and these are mainly antioxidants and vitamins like you find in preparations called Proceptin, Proceptin, and you can read more about that by going to a website called proceptin.com. And then there is Proxeed or Male Fertility Blend. All of these are rich in certain antioxidants and vitamins that enhance sperm fertilization potential. And then from the man's point of view, there are anatomical things that we need to be aware of and look for, and these include the presence of a collection of varicose veins in the scrotum of the testicles, known as varicocele, which increase the temperature around the testicles and cause reduction in sperm production. Usually when there's a varicocele causing a male problem, it produces what we call a stress reaction. And that means that the count is very high, but there are a lot of immature sperm forms in the mix, and the motility is low. So when there is a varicocele with a high sperm count, with low motility, and a lot of immature sperm forms, spermatids and so forth in the mix, that's when treatment may help, provided the man's FSH is not elevated, because if he's got an elevated FSH above 12 milliinternational units per milliliter, no treatment of the varicocele or removal of it surgically or by radio ablation is going to improve the sperm parameters. Now we come to the most important part of IVF evaluation and preparation. It's the evaluation for ovarian reserve. The ovarian reserve is defined as the number of eggs still available for use in the ovaries, because women start their lives off with a tremendous amount of eggs. By the time they reach puberty, they've got about 600,000 eggs in their ovaries still, having dropped from millions at the time of birth. And then it's a downhill process. And when the eggs fall below a certain threshold, the brain and the pituitary gland try to reawaken activity in the ovaries by causing the release of the hormone follicle stimulating hormone, or FSH. And it's this FSH measured at the first early part of the cycle, which if it's too high suggests that there's too loud a whip cracking sound. In other words, the brain is the mule driver trying to drive the mule is cracking the whip louder in an effort to get the ovaries to produce more eggs, but of course it can't. And the higher the FSH goes, the more it's indicative of diminished ovarian reserve. The woman's running out of eggs, and eventually it'll go so high that it almost is at the point of 70 or 80 milliinternational units per milliliter. When it's that high, the woman's about or is already in or about to go into menopause. The normal FSH level at the beginning of the cycle should be under 9 milliinternational units per milliliter. And that is, of course, provided that when you measure it concurrent with estradiol measurement. The estradiol level needs to be around under 70 picograms per milliliter, or 200 picomoles per liter, because if the estradiol is not low, and if it's higher than normal, it will falsely suppress the FSH, and you can't interpret a raised FSH or even a low FSH as being meaningful, because it would have been much higher had the estradiol been in the normal low range. But when the FSH goes over 9, that's when we start becoming concerned that there is too loud a whip cracking sound, the ovaries are running out of eggs, and we've got to thereby select a protocol for ovarian stimulation that takes into account that it's harder to stimulate ovaries that have got diminished reserve. But now there's a newer method of measuring ovarian reserve. FSH and estradiol must be measured between the 2nd and the 4th day of the period. But with AMH you can measure it any time. And if the AMH level is too low, it points towards diminished reserve. the units we use in America is nanograms per milliliter, and when the AMH falls below 2 nanograms per milliliter, it points towards a problem developing. But when it's under 1, if it's under 1, that means ovarian reserve is significantly reduced. And if it's under 0.5, it's very severely reduced, and it means that the woman is probably not going to respond as well as she should. And you need to be much more aggressive, but also very much more strategic in the protocols you use for ovarian stimulation. The antral follicle count, or AFC, is another method we use. We measure these little small 2 to 6 millimeter follicles in the ovaries, and we measure them around the time of the period of menstruation, at the beginning of the cycle. If the antral follicle count is too low, it's usually associated with diminished reserve. We like the antral follicle count to be over 10 overall, and usually it is significantly above 10 in young women with normal ovarian reserve. But if it's much below 10, it points towards the likelihood of not being able to harvest many eggs. So the antral follicle count is important, but it's sometimes difficult to read properly, especially in women that have got more adipose tissue in their pelvis, so that you can't see the ovaries as clearly. And then there's one we can also use called Inhibin B, which can be measured, and the Inhibin B, which we don't use much to measure ovarian reserve anymore. The higher it is, the more it's above 35, the more likely it is that the woman's got normal ovarian reserve. This is a picture of antral follicle count, and you can see this woman has got 1, 2, 3, and possibly a fourth one, and maybe a fifth one here in the shadows. But if you look at it in different cross sections, when we did look at it, this woman had 5 in her one ovary, so she has got only moderate or modest ovarian reserve. So based upon the determinants of ovarian reserve, we must plan our ovarian stimulation protocol. One of the problems, and I've said this over and over, is that when women get older, or when they have diminished ovarian reserve, their ovaries produce too much male hormone or testosterone or androstenedione. And in an environment of an excessive amount of ovarian male hormone, androstenedione or testosterone, eggs don't develop as well in the follicles. The key is to keep the testosterone and the androstenedione levels in the ovary low. There must be some, which is absolutely essential for stimulation, but you need to keep them low. And the way you keep them low is by suppressing LH. LH is the hormone that stimulates the androgen or testosterone production, and it's in the ovaries. And to keep it low requires the use of very selective protocols. The one that I like, or the two that I use almost exclusively on my patients, are long pituitary downregulation protocols. It starts off with a woman on a birth control pill, which is usually a combined pill, and she's on the birth control pill before her period comes along. And then as soon as the period, or a few days before the period comes along, she gets given an agonist. And the agonist example is Lupron or Buserelin or Superfact or Nafarelin. Approximately for 2 days they stay on the birth control pill with the Lupron, and then you stop the birth control pill and continue the Lupron until the period bleeding starts again. And at that point, when the bleeding comes 5 days later, you have two choices. You either continue with the Lupron by lowering the dosage, and with it combine it with the administration of fertility drugs that contain FSH, like Follistim and Gonalef and Minopure and Purigon, or when the period starts, you switch from the agonist Lupron to an antagonist such as Cetrotide, Orgalutron, or Ganirelix. When we switch from the one to the other at the time of the onset of the period, we call it the agonist-antagonist conversion protocol. Otherwise, it's just an antagonist downregulation protocol. And you continue either with the agonist Lupron at a lower dose, all the way through the stimulation to keep LH low, or you switch to the antagonist, which also blocks LH. And this is usually reserved for people that are a little bit more resistant, because we're scared that the Lupron, the agonist, may suppress somewhat of the response to FSH. So by switching from the agonist to the antagonist when the period begins, we can largely avert the effects of this suppression of response to FSH. And so the agonist is then supplanted with an antagonist, and this is continued to the day of HCG. The HCG trigger, and I want to say this is my personal opinion, and I want you to hear it as that opinion, but it really, I'm trying to be very deliberate in giving this opinion. It is not good enough when you lower the HCG dosage to 5,000 units from the normal 10,000. You must give a trigger shot of 10,000 units, and if you use the recombinant form of HCG, which is known as Overdrel, do not use just 250 micrograms, which is the regular dose. It's not enough. I found that when you do that, the quality of the eggs is compromised. In my opinion, you need to double the dose of the Overdrel when you use it, and give 500 micrograms, not 250 micrograms, which is equivalent to 10,000 units of HCG. Then 36 hours after the trigger, we remove the eggs. We do ICSI on those eggs, and then we culture the embryos. And in my program, all my patients, with very few exceptions, unless they make very few eggs or they're older and they demand it, will undergo blastocyst transfers on day 5. We now know with a relative degree of certainty that embryos that fail to make it to this advanced stage of embryo development, where the embryo is over 100 cells, have got chromosomally abnormal embryos, and they're not going to have a baby anyway. So we do not put embryos back. Whenever I can, I try to persuade my patients to go with blastocyst transfers. I'll put back up to 2 blastocysts. Anything additional is frozen by embryo vitrification, and those that are not used, the supernumerary blastocysts, are then vitrified in this way. About 7 or 8 days after the transfer, we will do a pregnancy test by quantitative HCG and repeat it 2 days later and see and try to find the levels to be doubling. During all this time, I like to support the luteal phase, that is after the retrieval of the stimulation, with progesterone. Well, general endocrine testing is important also. We need to know the woman's thyroid function for a number of reasons. If she's underproducing thyroid, it means she's likely already hypothyroid, and you need a normal thyroid balance for eggs and embryos to develop. But more important, as far as I'm concerned, is that if you measure the woman's thyroid stimulating hormone, or TSH, and you see it's elevated, even if her thyroid hormones are normal, it often points towards there being a condition that is developing called hypothyroidism, but it's before the condition develops. And that since the commonest cause of hypothyroidism in women is immunologic, due to the presence of anti-thyroid antibodies, and 50% of women who have such antibodies, whether or not they have reached the point of being clinically or endocrinologically hypothyroid, will also have activated uterine natural killer cells and an immunologic impediment to implantation. I like to watch the TSH very closely. If it's elevated, I will definitively test the woman for thyroid antibodies and for activated uterine natural killer cells and treat that, because if there is an immunologic problem, she's not going to get pregnant even if you fix the thyroid hormonal problem. And again, it's not necessarily only the reduced thyroid hormone levels that are detrimental to IVF outcome, but it's also the immunologic impact that is associated with the main cause of hypo and even hyperthyroidism, meaning natural killer cell activation. Then there are other hormones like prolactin, which we measure as well, which have a lot to do also with the uterine environment. And if the prolactin is very elevated, it may point towards a pituitary tumor. that we have to go looking for with MRI, called a prolactinoma, which is readily treated with bromocriptine or carbagoline. And then there is another condition called polycystic ovarian syndrome. Here we measure a barrage of hormones, FSH, LH, estradiol, androstenedione, testosterone, DHEAS, and 17-hydroxyprogesterone. These hormone levels can help us diagnose certain forms of polycystic ovarian syndrome, because normally in a non-PCOS patient, the FSH level is much higher than the LH. But in a woman with PCOS, it's often the reverse. The LH level is higher than the FSH level, and levels of male hormones such as testosterone and androstenedione may be high normal or slightly raised, and that in conjunction with clinical features will help us make the diagnosis. And also, of course, ultrasound examination, which shows the tremendous number of little microcysts under the capsule of the ovary in many patients with this condition. Now come anatomical factors, and this is what we also look for very, very closely. The anatomical factors we're looking for are first to evaluate the uterine lining. We were the first people in the world to show this back in 1989, that a uterus with a lining of 9 millimeters in its sagittal diameter, the fillade diameter, and one that has this triple line appearance, what I call a trilaminar appearance, is the one most likely to allow normal implantation to take place. So we go looking for the thickness of this lining at the time of stimulation, because it's estrogen that builds this lining. So we want to be sure that a woman going into an IVF cycle has a good endometrial lining, and the good time to measure it is around the time of normal ovulation, or in prior IVF cycles, to look at how that lining turned out to be during those regular IVF cycles. That's important. Or during the actual cycle that you're stimulating the woman, to evaluate how the lining grows, because if it's under 9 millimeters, it's not optimal, and if it's under 8 millimeters, if it's below 8 millimeters, this thickness here, then you've got a real problem in the embryo finding a place for its roots to attach properly. In such cases, implantation is impeded and miscarriage rates are much higher as well. In fact, I do not transfer embryos to a uterus where the lining is less than 8 millimeters, because that is associated with very poor outcome. Here's a lining with a very thin, less than 6 millimeters. This woman would not implant a pregnancy. Now, I'll tell you that in this particular case, treatment with a substance called Viagra or sildenafil, we were the first to show in the mid-90s that if you introduce Viagra into the vagina during stimulation with fertility drugs, what happens is the lining improves its blood flow very dramatically, and you get improved blood flow, relaxation of smooth muscle, and more estrogen. More estrogen can reach the roots of the embryo, which are located in the basal layer here. So if you use Viagra, you improve blood flow and delivery of estrogen to this basal layer, and through that process, the lining improves. There's another anatomical consideration, and that is that the uterus must have a regular contour of its cavity. In this one, we've done a sonohysterogram, injecting water into the uterus, which slightly distends the cavity, and here you can see a little polyp in the uterus. That's going to interfere with implantation, and it needs removal. It's easily removed at hysteroscopy by just plucking it out, and sometimes these polyps are flush. They're not on little stems like mushrooms. They flush with the uterine lining, and we actually have to scrape them out. But it's important to do a sonohysterogram in all women scheduled to do IVF if they've not had one done in the preceding 18 months. This is a hysteroscopy where you look inside the uterus, and here you see that same polyp. It's visible, and all we do is go in with a little scissors and cut the stem of the polyp and remove it from the uterine cavity. It's a completely benign procedure. It can be done under local anesthetic or with the patient asleep. Personally, I think it's better with the patient asleep. And then comes the last one, which is immunologic factors. Not all women have to be tested immunologically. I have come to the point now where I do test all for one screening test only, called a natural killer cell activity test. The natural killer cells, as I'll point out in a moment, frequent the uterine lining. They're good guys. Their role is to regulate implantation, and they release toxic substances, in some cases known as Th1 cytokines. Things like substances with fancy names like interferon gamma and TNF alpha. These cytokines attack the roots of the embryo and destroy it, and the woman often doesn't even know she's pregnant, or it damages the root system of the embryo, and the embryo limps along and then miscarries later on. The immunologic aspect of this is that these natural killer cells are in the uterine lining, and we test, and what they basically do is they produce two substances, two types of cytokines, Th1 and Th2. The Th2 cytokines attract the roots into the wall, and the Th1 kill the cells of the root system, of the trophoblast, by a process we call apoptosis. And this killing of the root system balances off the attraction, and so the root system grows into the wall, forms the placenta, which, as you know, is the lifeline to the baby. There must be the presence of both of these, must be present, and in a balanced fashion. We get two types of immunologic problem that will interfere with implantation. The most common by far is called autoimmune, where the body reacts to its own tissue by producing antibodies. These antibodies are antiphospholipid antibodies, anti-thyroid antibodies, and anti-ovarian antibodies. And what these antibodies do is they evoke the activation of natural killer cells and other T cells that are activated, called cytotoxic lymphocytes, in the wall, in the endometrial lining. And they then produce an increased amount of cytokines and a reduced Th1 cytokines, the ones that destroy the root system cells, and a reduction in Th2 cytokines. This, of course, leads to damage or destruction of the embryo's roots before you often even know that you're pregnant, and you lose the pregnancy so early you think you're infertile, but you're really having a very early mini miscarriage. Another form, a much rarer form of immunologic problem, is known as alloimmune. And the alloimmune type of variety is associated with genes known as DQ alpha and HLA. All people have these transplant genes. And it's important that the embryo be very different to the uterine lining, because if it's too similar, it will evoke the activation of natural killer cells and cytotoxic lymphocytes. So if the man shares certain DQ alpha and HLA genetic similarities with his partner, then the sperm that fertilizes that egg will result in the formation of an embryo that is too similar to the uterus of the woman, and that will over time provoke the natural killer cells, activate them with the same effect. The Th1 cytokines increased, Th2 reduced, and here, rather than the woman lose the pregnancy before she knows she's pregnant, she'll often have repeated miscarriages. This is a quite common cause of recurrent miscarriages. And we'll talk more about that in the question and answer session. So this is by way of a teaser to give you an idea of the subject matter, and hopefully many of you will have formulated questions already that I can address, and let's see if I can be of some substantive help in solving some of your issues. By the way, I forgot to mention, and I should have, sorry, what are the indications for immunologic testing? In endometriosis, 1/3 of the women with this condition, regardless of its severity, will have activated natural killer cells. Women who have autoimmune diseases like lupus erythematosus, rheumatoid arthritis, and hypothyroidism, either themselves or a family history and therefore a predisposition, may have activated natural killer cells, and you need to test for those things. And then recurrent pregnancy loss, as I've pointed out, is another cause that is another condition often caused by immunologic factors. And then there is women who have no explanation for why they're failing IVF. Everything else appears to be normal, but they keep on failing with good-looking embryos. Very often such women have got implantation problems that are often immunologic as a cause. I had a woman with this problem who lost 23 or failed to conceive 23 times with IVF in Australia, who had a baby after dealing with a natural killer cell issue. And then there are women that are often called unexplained infertile women. This unexplained is best, the name is best changed to undiagnosed, because in many cases it can be diagnosed as being due to an implantation problem that can be immunologic, anatomical, or the lining. The treatment for the immune problems, we're not going to go into detail, but the main one we use today is called intralipid. We infuse it into the woman's vein 7 to 14 days before the embryos are transferred, and this deals with the natural killer cells. The addition of the dexamethasone, which is a steroid, or prednisone, which is another steroid, is simply to calm down the cytotoxic lymphocytes, the T cells. In combination, prednisone and intralipid do the job in most cases. Okay, we'll go to the questions and answers now, and thank you for your attention. Okay, the first question comes from Melissa. No? Where does it start? Oh, right at the bottom. Go to the very bottom. Make it full screen and you won't have that problem. Okay. Now we'll see. That's good. The first one is from Donna. It says, I had pelvic inflammatory disease at age 17. I was not even sexual. Please help me get pregnant. Wow, Donna. Pelvic inflammatory disease is transmitted sexually. It's usually due to chlamydia or gonorrhea that damages the tube. Once the tube's been damaged, you need IVF. I urge you to give me a call, give our office a call at 702-699-7437 or 1-800-780-7437 and set up a Skype consultation with me so I can help you. Palak Gandhi, Dr. Sher, I've read that injections we take during IVF sometimes creates hormonal disturbances in cancer. Palak, this used to be a big concern in the late 80s, early 90s. There was a concern because one or two celebrities who'd been treated with IVF subsequently developed ovarian cancer. And there was the concern that there was a cause and effect relationship. But my dear, there is none. All the studies that have been done show that these drugs do not really increase the risk of ovarian cancer. And if you use it sensibly in women that are in women, you will not even really significantly affect the risk of breast cancer. Brittany Dono writes, I am 25 years old with stage 2 endometriosis, and I recently found out that I'm borderline positive for natural killer cells. Would I be a potential micro IVF candidate? Absolutely, Brittany. The infusion of intralipid is not a contraindication for micro IVF. Call 800-780-7437 tomorrow. Set up a Skype consultation with me, and I'll be very happy to help you if I can. As another question, could you give me a little more information of what that is? I don't think I get that question. I'm sorry, Brittany, you'll have to rephrase it. Melissa Felton writes, what would you recommend that a patient do from a nutrition and exercise perspective to prepare for a cycle of IVF? When should we cut out alcohol and caffeine? And when should we cut down cardio and weights? Cut down cardio and weights. Melissa, you have to do things sensibly. eat sensibly, a balanced diet, keep caffeine at a minimum, and try to get a reasonable amount of exercise without overdoing things. The only time when you can really do harm with alcohol is after the embryos are transferred. Remember, your eggs have been in your ovaries all your life. So whether or not you don't use alcohol while you're being stimulated is not going to affect the quality of those eggs that we harvest. Alcohol's problem really is with the effect on the developing and implanting embryo and the developing baby. So you don't want to use alcohol after the eggs have been removed, after the embryos have been transferred to the uterus. Caffeine should be kept at lower level as possible, and of course nicotine is not a good thing either. Okay, and as for exercise, again, there's nothing wrong with exercise, but once you've had IVF done and the embryos are transferred, you should keep whatever exercise you do to just to a low pace, and it should not be high impact exercise. Simply stated, this is not the time to go skydiving. Okay, Christina, do you have cycle statistics on frozen sperm versus fresh sperm? Frozen sperm is just as good as fresh, provided that in the fresh state it came from a man with normal sperm function. If the sperm function is reduced, then you will have poorer quality sperm and poorer fertilization if you use frozen sperm, if you freeze that and use it. Dr. Sher, since I'm infertile, how would I find out if I ovulate? You know, Donna, the only absolute evidence of ovulation is pregnancy. You can see, you can get a good idea as to whether you're ovulating from doing home ovulation tests where you measure the LH surge that occurs some time before ovulation occurs, but that is not proof that the egg's actually been released. Some women will have the surge in LH, but the egg will remain trapped in the ovary. And that's why I say the actual proof of ovulation can only come from pregnancy or from seeing the ovulated follicle at the time of doing a laparoscopy. But the best way to predict when ovulation will occur is to take, if you're having regular cycles, you usually ovulate about 14 days before you menstruate. So about 10 days into the cycle, that means 18 days before you menstruate, start using the home ovulation kit and you'll see the color change occur. And when it occurs, it means that ovulation is imminent. Another way of testing whether ovulation has occurred in retrospect is with a basal body temperature chart. If you chart your temperature every day, you'll find that after you've ovulated, it'll go up because of the effect of progesterone. It'll go up a notch and it'll stay up. That's another indication that ovulation occurred at the time just before the rise. But remember, everybody, you're not going to get pregnant on your own by having intercourse after ovulation. It's before ovulation, immediately before, and that's why the LH surge and measuring it in the urine is so helpful. Then is it now? Christina says, can estradiol be too low on cycle day 3? Some people say that if the estradiol levels under 15 picograms per milliliter, it can point to a potentially poor response during the cycle. But I'll be honest with you, Christina, I don't believe that to be true. Brittany says, of course, Christina, by the way, if your estradiol is low because you're in the menopause, well, then, of course, you're not going to ovulate and you're not going to be successful in any IVF cycle with your own eggs anyway. Brittany writes, I know that every woman reacts differently, but when are most women medically emotional during the IVF cycle? You know, it's very difficult to answer that question, but I can tell you that it's most likely to be with major shifts in the hormone levels. So as you're under the stimulation with the drugs, you tend to find that as the levels rise very rapidly, and they can rise 20 times above the normal, that's when you start seeing emotional shifts in some women. And you also see it with progesterone coming on board after the extraction of the egg and the administration of the HCG. The progesterone can also produce emotional reactions. Do embryos grow to blastocyst stage before the cells are sent for CGH testing? Christina, that's a good question. There are two types of CGH tests. The one is called metaphase CGH. The other is called array CGH. In my opinion, array CGH should only be done on blastocysts. There's not enough DNA in a single cell to rely on that small amount that you take from one single cell on day 3 to do array CGH on. What you need to do is have several cells that you remove from the embryo and pool the DNA together to have enough DNA to do array CGH. And that is why array CGH should only be done on blastocysts. But metaphase CGH can be done earlier on. Metaphase CGH can be done on day 3, and I much prefer metaphase CGH for one very important reason. You get the test done on an earlier embryo before so many cleavages or divisions have taken place in the cells that can cause them to become abnormal through replication division. When cells are abnormal in the embryo because of this process we call mitosis or replication division, as it goes from day 3 to the blastocyst, many of these types of abnormalities are self-reversible, and the woman can end up having a normal baby even if the array CGH is abnormal. So I think you get much more reliability from a day 3 metaphase CGH test. We use that, and I use that almost exclusively unless the woman wants to know the gender, the sex of the embryo, in which case the country in which we do those tests will not allow us to do gender selection. So then I send the embryos for array CGH as following blastocyst biopsies. If egg retrieval resulted in 2 great-looking eggs but no embryos formed, does this occur often? Is this unusual? It does occur often because no matter how good an egg looks, you can't see the chromosomal makeup of the egg through its outer surface. Would you check my eggs to see if I could use my own eggs? Of course, Donna. Again, give us a call, 800-780-7437. Set up a Skype consultation and we can discuss it. Melissa Fenton writes, I had immunological and thrombophilia testing. All testing was normal with the exception of PAI1, and which was abnormal for the thrombophilia. What is the protocol for this? Well, certain thrombophilias can be treated simply with folic acid, like certain MTHFR, heterozygous, that means a single mutation problem. Some, such as factor V Leiden, or homozygous, that means 2 mutations for MTHFR, and perhaps even the one you referred to here, are best treated with heparinoids. But the treatment is only really needed after you're pregnant. This is not something you have to start doing before you've established at least a positive pregnancy test. And contrary to what most people will tell you, thrombophilias, which are hereditary clotting defects, do not usually cause miscarriages. They cause problems in later pregnancy and problems in the 3rd trimester of pregnancy that can result in serious complications, resulting in compromising or killing the baby. But immunologic testing is different to thrombophilia testing. This is testing for natural killer cells, phospholipid antibodies, thyroid antibodies, DQ alpha and HLA testing for the alloimmune types, things I mentioned earlier on. And those you do earlier on because the treatment must begin long before the egg retrieval is done. What would the main cause for apparent nice quality eggs not developing into embryos? Is one time likely a fluke or indicative of a problem with the eggs? The most important issues that affect egg quality are the age of the woman. The older the woman gets, the less likely it is the egg will be chromosomally normal. At the age of 30, 1 in 2 eggs are normal. At the age of 45, 1 in 20 is normal. So even if the egg looks normal, its chromosomes can still be abnormal. So age is the most important factor. And after age comes the protocol used for ovarian stimulation. You've got to be very, very strategic and individualized in how you stimulate women when they have got diminished ovarian reserve, especially, or they're older, because you can corrupt the eggs in the process. Could you use vaginal Viagra for an FET? Absolutely, and we do, with great success very often. Melissa Fenton said, would you recommend repeating the fluid ultrasound after several failed IVF attempts? Not usually, because if you've done one quite recently, you're not going to get polyps forming so quickly. But if it's been over a period of a year or longer, I may well do so. Can you find out if I ever was pregnant? That's not so easy. But if you've been pregnant, if a woman's been pregnant and given birth, or been beyond the first trimester, simply looking at the cervix will show the lacerations, which will tell me easily if that woman had been pregnant that far. But very early pregnancies may be missed, and you won't very easily see telltale signs of the pregnancy having occurred. Sometimes if the woman's been pregnant, the pigmentation around the nipples gets darker, the areola. If you see a woman with a dark areola around the nipples, you can almost certainly know that she was pregnant sometime in the past. I've had 4 miscarriages, says Christina, in total. 2 with my husband and 2 with my current partner. One was an ectopic. It's very likely that an immunologic factor could be a problem. Christina, let me tell you something here that's very important. If you took a survey in the United States as to what were the commonest cause of miscarriage, you'll find that most miscarriages are due to chromosomal embryo abnormalities. But these are sporadic miscarriages. You miscarry, you have a baby, you miscarry, you have a baby. And overall, no question, embryo problems are the commonest cause. But when it comes to recurrent miscarriages, more than 2 in a row where a woman keeps on miscarrying, lightning striking at the same spots, it less commonly is due to chromosomal issues and more commonly due to immunologic or other implantation problems. Let me just take a little sip here. Brittany writes, I did 2 rounds of Clomid, both negative. On the second round they tested to see if I ovulated. I did not. But could this be because I had undiagnosed hypothyroidism? It is possible, Brittany, but it's very common that in 20% of cases of women on Clomid, the woman won't ovulate. She'll go through all the changes associated with ovulation, but the egg will be trapped in the ovary. We call that luteinized unruptured follicle syndrome, or Luff syndrome. That's one of the problems with clomiphene, is that it causes this trapped ovulation in 20% of the time that you use it. Are there any tests you can do if you have ever been pregnant and miscarried before knowing? Unfortunately, Amy, you cannot. You've got to have the problem to test and know exactly what you're dealing with before you start testing. Palak Gandhi writes, I have Hashimoto's, hypothyroidism. Palak, that is an autoimmune hypothyroidism due to antithyroid antibodies. It's got nothing to do at this stage whether you keep your thyroxine levels balanced. 50% of women with antibodies will have natural killer cell activation and an immunologic implantation problem. It is reversible. It is treatable if you treat the right thing. Treating with hormones, levothyroxine, is not going to solve the immunologic problem. I urge you to give me a call at 800-780-7437. Let's have a Skype consultation, because I think I can help you, Palak. Brittany Donahue, it's okay. What is micro-IVF? Micro-IVF is just a watered-down IVF procedure, because these are young women who could also be candidates for intrauterine insemination, but IVF is much more successful. These are women that don't require much fertility drug to stimulate them. The monitoring is much less, the amount of work involved is much less, and so the cost is much lower. Lillian C. I've unexplained infertility, trying IVF for the first time. How can I know if my problem has to do with implantation? Well, they've got to measure your uterine lining at the time of ovulation to see if it is at least 9 millimeters or at least 8 millimeters in thickness. Someone's got to look inside your uterus, not with an HSG, not with a dye X-ray, but with a sonohysterogram when you inject water into the uterus, or you do a hysteroscopy to explore the inside of the uterus, and then you need immunologic tests to make sure that you don't have an immunologic factor. That would be very helpful. If those are normal, all of those, then you start looking at problems with the egg, and that's where you start doing more sophisticated testing on egg quality. But usually you're going to find the problem with the implantation side when it's unexplained. Do all SRM offices follow the same procedures as your Las Vegas office? We previously worked with the doctor in St. Louis and are considering working with Dr. Dayal. I cannot talk for other doctors, but Dr. Dayal went through, I've been working with Dr. Dayal for a year. I can tell you without equivocation, she's probably one of the finest reproductive endocrinologists I've ever had the privilege of working with. Her results are incredibly high, and I think working with Dr. Dayal, you'll get exactly the same approach to treatment as I like to think I would give you. She's an outstanding doctor, and I'd have no hesitation in recommending my own daughter to her for treatment. There? Yeah. I teach and try to be very aware of how I'm acting around my students. Would it be wise to wait until the stomach to do an IVF cycle? I'm very open with my students, but I don't want them to suffer if I'm being crazy. No, Brittany, you're not going to be crazy. Nothing that you couldn't handle and control yourself. I don't think that's a reason to delay IVF, Brittany. You say also, sorry about all the questions. Can you repeat your number of what your office hours are? Well, I'm in Las Vegas, so you want to call 1-800-780-7437. Speak to Shelby. Shelby's fabulous. Ask her to set you up with a Skype consultation with me. I don't do consultations by phone. They're too impersonal. I like to see the people I'm talking to. And so call Shelby at 800-780-7437. I'm in the office every day from 9 till 5, and she'll set you up for a consultation. Lillian says, I'm 30 years old with unexplained infertility. My FSH is 6. My AMH is 1.6. Would I still be okay with mini IVF? Mini IVF is not something I personally like to do. I know there are a lot of people that do it, and you may be, if anybody is a candidate at your age, you would be. But with an FSH, with an AMH that's already below 1.6, I'd be looking more towards micro IVF, which uses injectable fertility drugs rather than clomiphene and letrozole, which I think are very bad drugs for women that have got diminished ovarian reserve, as you already have with your AMH of 1.6. You say, I've been taking care of my 80-year-old mother, and there's much pressure in her home. My period has been sporadic. Am I going through menopause? Sorry, you said you're 48 years of age. Where's that? Oh, you said you're 48 years of age. Well, more than likely it's possible that you are, but not because of the stress you're living under, but more because you're probably starting to run out of eggs. And at this stage, you are definitely going to need to consider using an egg donor. Christina, do you prescribe estrogen as well as progesterone after transfer? Yes, we do, either vaginally or by injection, depending upon the protocol we're using. Ruth writes, my diagnosis is unexplained infertility. I've had 2 frozen embryo transfers, both unsuccessful. I'm 29 with excellent looking blastocysts. My RE doesn't believe in immune testing. Well, that's your RE's problem, I'm afraid, Ruth. He's got to deal with it. If he doesn't believe in it, I can't help you. But to exclude immunologic testing in a case of unexplained infertility, in my opinion, is ludicrous. Jackie Riley says, what's the highest dose of Brevell that you recommend combined with Menopur? Jackie, some doctors use Brevell in IVF. I personally do not. I prefer to use recombinant FSH in the form of Folistim or Gonal-F. I'm not saying Brevell's not a good product, but I like to use the most pure form of FSH I can use because I think it's more predictable how the person will respond, and there's less batch-to-batch variability in the biological potency of the drug, in my opinion. Rodding says, is it possible to have immunologic factor if you've already had a child? Absolutely yes. Absolutely yes. And when that happens, it's very often the one that's the toughest to treat, called alloimmune implantation dysfunction. It's very common to find people that have had a child and then can't get pregnant at all, or continue to miscarry after that and then can't get pregnant. That's not an unusual presentation for alloimmune implantation dysfunction. I urge you to call 800-780-7437 and set up a Skype consultation so I can work on this with you and help you determine whether that's your problem, Rodding. Dr. Sher, do you think a positive ANA can affect the outcome of IVF? No, but a positive ANA points towards a primary autoimmune problem. And women with primary autoimmune problems have got a high likelihood of having activated natural killer cells, and that can affect outcome. There's another question by where am I?
Here. Just wondering where to ask questions.
I'm hoping to be in the December cycle. I'm 28 years old with endometriosis. My husband has poor sperm morphology. Is there a success rate for IVF? I think at your age, the chances of success are very, very good. I don't want to give you a number, but I will say that in my experience, the vast majority of women of your age will have a baby within 2 attempts. And I would say above 80% if you include the fresh and the frozen cycles included. Donna, where's it now? Donna writes, when I was young having my period, they were painful. The doctor said I had PID. If I had to, it had to be the wrong diagnosis. I know I was infected with chlamydia and then trichomonas in my 30s. Those trichomonas won't cause pelvic tubal damage, but chlamydia sure would. Donna, that is a fait accompli. Mary Castillo writes, I had 2 failed IVF cycles in 2012 at the New Jersey office. I presume you mean SIRM office, and I'm concerned of failing a 3rd time. Should I consider a different doctor? I'm so worried about another expensive failure. We did test negative for natural killer cells. I think maybe you should go back and speak to the doctor there about possibly testing you also for, there you said it, CGH testing, and you had perfect embryos. Marie, I don't believe that you don't have an immunologic problem. If you have a good uterine lining and you did get pregnant with CGH normal embryos, it points very much towards the likelihood of there being a immunologic problem that's not fully diagnosed. If you want to, speak to your doctor, to Dr. Peters again, ask him to look at it more closely and have him give me a call. I'll be happy to discuss it with him and see if we can work out what's going on with you. Rodding writes, is it possible to have immunologic factor if you already had a child? I think I answered that already, and the answer is yes, Rodding. It is definitely possible, especially the alloimmune variety. Tara Brodden writes, I have 0.16 AMH, 38 years of old, 3 failed IVF cycles. Well, Tara, you've got extremely poor embryo ovarian reserve, and you should be looking post-haste at the possibility of embryo banking with CGH embryo selection. Embryo banking is where you should be going. I urge you, go to my blog, www.ivfauthority.com, ivfauthority.com, and when you get to the search bar in the upper right-hand column, type in the term embryo banking and click on it. It's going to take you to the articles, because embryo banking might well be the way for you to go before it's completely too late for you. Lillian says, I live in New York and I have a consult with Dr. Tortoriello. You are going to one of the finest doctors that you can find. Dr. Tortoriello is unbelievably fantastic. He does exactly what we do, and he's going to walk you through these problems the same way I will. Christina, how do I do your fresh cycles compare with your frozen cycles? Christina, we get as good, if not better, results with frozen cycles than fresh. Now, with the new form of freezing called vitrification, the embryo isn't harmed in any way. So frozen embryos, if you freeze blastocysts, but you've got to freeze blastocysts for that to be valid, give you as good, if not better, results than fresh? Would chromosome testing before embryo transfer improve the outcome? It depends on whom. It's not something I would be doing on a very young woman. It's something I'd reserve for older women or women with diminished ovarian reserve or women with polycystic ovarian syndrome, all of whom have a greater tendency to have chromosomally abnormal embryos. Thank you, Donna. Appreciate you. Thank you very much, Christina, also. That brings us to the end of this session. But before I say sign off, I'd just like to say thank you all very, very much. This was a difficult one because it was very broad, but I hope it gave you some insight into the things we look for in evaluating and preparing people for IVF. Please feel free again to call 1-800-780-7437 and set up a Skype consultation with me, and I'll be very, very happy to talk to you and try to help you through some of the issues. And I'm going to call it quits there. Any other questions, I ask you to please post on haveababy.com on the SRM Las Vegas discussion board and on the IVF Authority comment section, and I'll answer those questions as well. Thank you all very much for your time. Really appreciate it.